Welcome to today's web chat on breast cancer. Thank you for joining us. My name's Ed Bottomley. I'm going to be your host for today's chat, and we have our two panelists with us. We're going to meet them in a moment, but first I wanted to talk about a few housekeeping items. You can submit your questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please know that if you do comment, your name or your profile name will be visible to others participating. Now, if you prefer a more anonymous option, you can send a private message to us on Facebook or on Twitter. If you can't stay for the whole chat, or if you want to share the recording of this chat with a friend, a video of the chat in its entirety will be available on our Michigan Medicine Facebook, Twitter, and YouTube pages, as well as our Rogel Cancer Center social pages too. So now on to our panelists. If you could introduce yourselves.
Hello, I'm Sofia Merajver. I'm a medical oncologist at the Rogel Cancer Center, and I run the high-risk clinic for individuals at increased risk for breast and ovarian cancer.
Hi, I'm Jacqueline Jeruss, and I'm a breast surgical oncologist also at the Rogel Cancer Center, and I am the director of the Breast Care Center.
Thank you so much both for joining us. Let's jump right in with our questions, and we have them segmented to different topics. First, we have detection and diagnosis. First question we have up, why do they keep changing the age for starting to get mammograms?
So I'm happy to address that. I think that to try to be as clear as possible, at the University of Michigan Rogel Cancer Center, we recommend the guidelines that are put forward by the American Cancer Society as well as the American College of Radiology, which would suggest that a baseline mammogram be obtained between ages 35 and 40 and after age 40 every year, with the understanding that every other year is also an option based on a conversation that a patient would have with their physician about their familial risk and other risk components. I think it's important to state that at the University of Michigan, 20% of our patients' cases are diagnosed under the age of 50. So with that information in hand, we strongly recommend that patients begin their mammogram at age of 40, and I think that's been a long-standing recommendation.
Thank you. Anything to add, Dr. Moran?
Well, thank you. I totally agree. Furthermore, there are times where it's appropriate to start earlier, such as individuals who have a particularly high-risk situation, like carrying a mutation to a particular cancer susceptibility gene or a special family history structure. We may recommend earlier. Mm-hmm. But for the person at average risk, we very much recommend starting around 40.
Thank you both for that. Our next question we have up, how important is self-examination and when should one start it? How does one do a self-exam?
So I think that self-exam has become more controversial as of late, as it sort of lost its advocacy from some of the more prominent cancer organizations, but we advocate for self-exam for patients because I truly stand by the fact that I think the patient is their own best advocate. And so we would really want a patient to feel comfortable with their bodies and to know their bodies. And I think this goes beyond issues associated with breast health to a global sense of wellness that we would want each patient to feel confident about. That being said, I think that once the patient feels comfortable with themselves and their bodies, to examine themselves once a month, typically mid-month, the same time every month, and feel confident that if they have any concerns or questions about changes in their exam, that they could come forward and speak to a physician at the University of Michigan to help better define what their concern might be.
Yes.
Great. And the next question that we have up, my doctor has asked me to come back for a second mammogram. Does that mean I have breast cancer?
I think that's a great question, and certainly something that creates a significant amount of stress for patients when it happens. And so I think the best way I can answer this is by putting the numbers out. And I had the chance to discuss this question with my colleague, Dr. Colleen Neal, who is the director of breast imaging at the University of Michigan. And so here are the facts. About 1,000 patients come in for screening. Of those 1,000, 100 will probably be called back for a second assessment. And I think that that probably means that in a patient's lifetime, the likelihood is very high that this will happen, and it really has to do more with the ability to obtain the type of imaging projections that are needed that may not be attainable on a first screening assessment. Important to state, though, of those patients that get called back, only 2 or 3 of those patients are going to be diagnosed with cancer. So the likelihood of this translating, a second callback, likelihood of that translating into a cancer diagnosis is exceedingly low. But the likelihood of a callback in a lifetime is actually quite high. But just to obtain the right amount of pressure so that the imaging can be resolved.
Thank you for that. The next question asks if you can tell them more about a regular mammogram and a 3D one.
Yes, also an excellent question, and one that I had the chance to talk about with Dr. Neal. So 2D is really a traditional imaging modality that you would be obtaining if you came to the cancer center for a standard screening exam. 3D mammography is distinct, and it's what we now understand to be tomosynthesis, if you hear that term being used. And the distinction between a 2D and a 3D image is that a 2D image really takes images in specific directions that are stable at the time. A 3D image has more variability and is able to obtain images of the breast in various angles and may help to better define more subtle findings in a patient's exam, specifically for patients who potentially are at higher risk or are thought to potentially have dense breasts. And so I think the other component I want to address is that while 3D imaging is associated with more radiation exposure, both the amount of radiation from a 2D imaging exam and a 3D imaging exam is exceedingly low.
Thank you for that. Anything to add, Dr. Merajver?
No, I think the 3D images are really a very big advance, and they do help detect sometimes hidden structures. And so if you're recommended to have a 3D mammogram, which we sometimes recommend in our high-risk clinic, by all means, make sure you go to a center that offers that.
Thank you for that. The next question, now this is something that you mentioned in your previous answer. How does one know if one has dense breasts?
So this has become a very also intense topic for patients, specifically if they obtain a letter from an imaging center that states that they have dense breasts. And so again, I think putting numbers to the percentage of patients who may obtain a letter like that, approximately 50% of patients in the United States will be categorized as having dense breasts. And there are 4 categories of breast density that have to do with extremely dense parenchyma to mostly fatty replaced. And so dense breasts are not abnormal. They're a component of life that has to do with likely the hormonal environment and the age at which the patient is being studied. So that being said, if there is a question about breast density that is of concern to the imager based on a 2D or 3D mammogram, imaging can be supplemented through the use of additional targeted ultrasound or potentially MRI if the patient is thought to have other components of risk in their history.
Thank you for that. This next question is a little bit of a broader one. What are the different types of breast cancer?
So I'd like
yes,
so
breast cancer, up until about, I would say about 30 years ago, we talked about breast cancer essentially as a single disease with maybe some individuals having expression of the estrogen receptor and being typically described as having more what we call indolent or sort of lazier cancers that don't proliferate so fast, don't divide so fast and grow fast. But it has been really in the last 15, 19 years where there's been an explosion of our understanding of breast cancer being many, many diseases. So starting with the differentiation, the difference between having estrogen receptor expression in the breast cells and not having it, and then the expression of other markers that contribute to the development of the cancer itself, notably the progesterone receptor as a second hormone receptor, And then the third one that is really important is a driver. We call it a driver, something that encourages the cancer to really not respect boundaries and grow and invade, and that's the HER2 gene, HER2. And if that gene is very strong, because there are many copies of it in the cancer cell, not in the normal cells, but in the cancer cell, we can detect that, and that's usually a very important driver, and is very important for people to know, and that's why that test is done routinely across the board in almost everywhere in the world to decide on treatment. So right now we know we have estrogen receptor positive cancers that may or may not express the HER2 gene, and then we have some breast cancers, a category of its own, but a very important one, where all three of these genes are either low or not expressed at all. And we call those sort of a basket. We put them all in a basket called triple negative breast cancer. The truth of the matter is, if we have some audience right now who's interested about triple negative breast cancer, I really want to say that in triple negative breast cancer, we are a little bit today the way we were in all breast cancer about 30 years ago. We still call it a single category, but it turns out that there are probably 6 to 8 to maybe 10, maybe 20 different categories of triple negative breast cancer. So we are continuing to do tremendously important research to really understand the biology. And the question, why the question is so important, is because the treatment depends on these biological characteristics.
Thank you for that. Anything to add?
You know, I want to stress that I think there was a time in the not too distant past where patients felt that their disease biology was really likely to dictate a specific endpoint. But to speak to Dr. Merajver's point, I think we really look at these markers now as an opportunity to implement targeted therapeutics. And there's really never been a time that's more exciting than now in research and in translational science and in clinical care, for us to take the information that we have been working hard for in the lab and actually exploit it to a patient's benefit to obtain targeted therapeutics. And so I think it's a time to feel very optimistic about where things stand with breast cancer care.
Yes. All I would like to add before we leave this topic is there is one type of breast cancer that I can't miss mentioning. It is the rarest form. Only about 2 to 3% of white Caucasian patients have this type of breast cancer, and only maybe 4 or 5% of African Americans have this type. It's called inflammatory breast cancer. And this is a type of breast cancer that presents with a red, inflamed breast. Sometimes it has some dimpling of the skin, resembling, for example, the skin of an orange. This is a severe case of breast cancer that needs to be attended, and it's extremely treatable and curable if it is caught very soon. So patients who present with this rare form, who have a sudden onset of redness in the breast, they should seek medical attention, because it is an urgency and it can become an emergency. And so I wanted to mention it because also this type of breast cancer cuts across all the other receptor types. It can be estrogen receptor positive, it can be estrogen receptor negative, etc. But the presentation in the breast with the redness and the swelling is very specific. Other conditions such as infections can present that way, and that's why seeking very prompt medical attention is really important. In talking to your doctor, if you have that problem, about potentially a biopsy the first time you see the doctor, just bring it up. If you're listening and you have this problem, go to your doctor today and bring up the topic of getting a biopsy.
Thank you for bringing that up. Next question that we have: what's the screening process with a patient who had bilateral mastectomy with saline implants reconstruction?
So for those patients, we traditionally rely on physical exam as the primary screening modality. But I do want to take the time to address the recent FDA new advisory that was issued just this past week, delineating that patients who have implants, saline or silicone, should now seek an exam, either with ultrasound or MRI, physical exam, every 5 to 6 years, with the understanding as follows, that implants are not intended for a lifetime and that they may require maintenance and should be evaluated at least every 5 to 6 years.
Thank you for that. We have another question that's come in. If my breasts hurt even when I'm not on my period, does that indicate anything?
I want to stress first and foremost that breast pain is something that's very common. And Dr. Merajver and I see patients with breast pain every week in our clinical practices. That being said, it can be quite alarming and concerning. And if you have concern about your exam, it's very important to come in and be evaluated to make sure your imaging is up to date and then also have a physical exam. I also want to stress that breast pain can be managed, and there are many different modalities that we recommend in the breast center that have to do with caffeine modification of intake, the amount of exercise, upper body strengthening, the use of a supportive bra, that all can help to contribute to the decrease in the incidence or the experience of breast pain.
Thank you for that. The next question, a little bit of a change of topic. How is male breast cancer detected?
Well, male breast cancer is relatively rare, but it does happen. And unfortunately, it turns out that over the years, it's been documented that men tend to ignore little bumps and lumps in their breasts. And they really shouldn't, because a man has really not very many reasons to have bumps and lumps on the breast, in contrast to a woman where during the reproductive years, especially close to their periods, the breast can become more lumpy, and women are accustomed to feeling that in their breast self-exam, which I completely agree with Dr. Jeruss. We should encourage women to do so that they know their bodies better and they are able to detect differences. Well, the same holds true for men. And men detect it very easily because there is less tissue, it's easier, and then they do nothing about it. So if you're a man listening in, or if you are a woman and you are concerned about a male person in your life who may be having an abnormality, something that he has shown you or you have felt, do not be shy and encourage him to seek attention, because sadly, many men are detected eventually, are diagnosed eventually much later than they should have been. They delay diagnosis, they just ignore a little bump that's not hurting. And male breast cancer is almost never painful. Because there is, again, a lot less tissue, so there is no pressure or less likely to be pressure. Once it's diagnosed, if we compare the extent of disease, we call that stage in cancer, the prognosis is almost the same, although, again, sometimes the delayed diagnosis causes the cancer to have become maybe a little more advanced or aggressive. And so we are concerned about that. And so encourage everyone who feels a lump to have it checked by your healthcare provider as soon as possible.
I just to frame the context, though, I think it's important that we understand what the incidence is. And just like the incidence of inflammatory breast cancer that was just mentioned by Dr. Merajver is a great concern, the incidence is very rare. We're talking about just about 3,000 cases of inflammatory cancer that are diagnosed every year. And a similar number of male breast cancers are diagnosed every year. In fact, about 2,600 cases are expected to be diagnosed in men this year of breast cancer. So I want patients to understand that the risk of being diagnosed with these findings is low, but just the same. What we want more than anything else is to address a diagnosis at the soonest possible time point. So awareness is so foundational to understand these problems and to feel comfortable coming in, seeking help from a physician to provide clarity for whatever it is that concerns you.
I cannot think of any exception to the rule that treating cancer at the earliest possible time is better. So
Agree.
Not
Agree.
just for breast cancer, but for any cancer.
Yes.
So bumps
Yeah.
and lumps, try to not ignore anywhere in the body.
Yeah.
Thank you. Next question we have up, does a dimple in your breast always indicate breast cancer?
I would say that we want to see patients who have new changes, whatever they may be, in their breast exam. But a dimple more than likely is an indication of potentially the just normal maturation process of the breast. But it would be a finding that would indicate to us that a further workup is necessary and would be very much an appropriate reason to come in and seek additional physical exam care and imaging care.
Exactly.
Thank you. Thank you for fielding all these questions. We're about a third of the way through now, and we're going to change topic onto treatment options. What are treatment options for breast cancer?
Well,
Yeah, I mean, I think what
You
I would
wanna get
say,
started?
I'm going to say the broad overview
Sure.
tends to be that we offer our patients surgery, systemic therapy, which would include chemotherapy, anti-hormonal therapy, bioimmune therapy, other targeted immune therapies as well, and radiation. And so those are the three big standard approaches that we use to implement the fight against breast cancer when a patient is newly diagnosed. And I think Dr. Merajver was going to talk specifically about our systemic treatment options.
sure. I mean, not everyone, but many patients will require treatment beyond surgery. Some patients are cured with surgery alone. Depending on the type of surgery, most patients that do not have the whole breast removed will also require radiotherapy. So those are some combinations of therapies that some patients with very early cases or very benign biology, so it's still a malignant tumor, but the biology is favorable, then they might not get the other therapies. Also, some patients for whom there are no other therapies to offer may also just stop at surgery or radiation. Patients who are older adults who have other medical conditions. So there are no cookie cutter sort of recommendations for everyone. Mm-hmm. But if somebody's told that you need therapy that goes everywhere in the body, I want to take a second here to explain, maybe a little more than a second, why that is, because patients are always puzzled. I have the tumor right here, and why do I need something in my bloodstream, or why do I need to take a pill where it goes everywhere? A lot of our patients say, I don't like medicines. And so let me take a minute to explain why it's worth very seriously considering your doctor's advice if they discuss with you why you should take this therapy we call systemic. Systemic meaning it goes everywhere. And the reason for that is that in spite of the amazing skills of the surgeons, such as my colleague Dr. Jeruss right here, who is an amazing practitioner of surgery.
Thank you.
Yes.
And I feel the same about you.
Well, we have to take a minute here to tell the truth. Nonetheless, she cannot know whether 100,000 cells or 1,000 cells or even 1,000,000 cells have left your tumor before she got to it. It is impossible to know that. A 1 centimeter tumor, which is a rather small tumor, we call that stage 1 in breast cancer, still has, right now, we estimate 500 million to 1 billion cells. Now imagine if you had $1 billion yourself. Would you know exactly where $10,000 are? Maybe you would, but maybe you wouldn't. Mm-hmm. So that is the situation. Yeah. 10,000 cells could have left your tumor, and those are the cells anywhere in the body that may be there. I'm not saying they are, they could be. Mm-hmm. So we want to kill them while they are circulating in your bloodstream and maybe lodging themselves in some organs, and they could stay there for many years. Yeah. So that is the purpose. That is why we as oncologists will suggest fairly strong drugs. Let's face it, The drugs in cancer are the really strongest drugs we have in all of medicine. I think most doctors in every specialty would agree. So you are going to be treated at a specialized center by doctors who are very experienced using these drugs. You want to get the right drug, you want to get the right dose of the drug for who you are as a person, everything else that's going on, and you want to get the right spacing of the drug. We call that intensity. So everybody gets the treatment, but it isn't done the same. The side effects could be different. The drugs that we give you to prevent side effects, so you need to go to a specialized center that has experience with your type of breast cancer. And so you may get then the therapy. You may sometimes get the chemotherapy before Dr. Jeruss does her surgery, because the point is to shrink the tumor maybe, but also to find out if your tumor was responsive to that therapy. So there's a lot to be learned by that scenario. We call that scenario neoadjuvant chemotherapy. So after all that therapy, many patients also need to take a pill, which is a hormonal anti-estrogen, essentially estrogen modulators, we call them, pills. And there are several different types of patients will get different ones. And again, we talked about the HER2 oncogene, the HER2 gene before. Many patients will then go to one or two drugs against that oncogene if that oncogene is active. So there are all these diversity of treatments, and they will all be explained to you if you need them. You should ask all of the questions, and there should be a lot of dialogue as to what's expected to happen when you get these therapies. But I want to reassure our listeners, our viewers, that it is extremely safe to receive therapy for early stage breast cancer. Extremely safe. They are strong drugs, of course. Is it going to be a bit of a challenge? Yes. But you and your healthcare team and your support at home will get through it well.
Mm-hmm.
Thank you for that, very important. Mm-hmm. Next question we have up. I recently had a lumpectomy for DCIS, will finish radiation treatment shortly and begin hormone therapy soon. I tested positive for the CHEK2 mutation, CHEK2, and I've been told I will need yearly mammograms and breast MRIs for quite some time. I have cochlear implants, which complicates but doesn't make MRIs impossible.
So this is a very interesting question and a very patient-specific question that I think we could answer on broad terms today, but that I do want to be thoughtful about in the sense that, as Dr. Merajver so eloquently just stated, everybody's treatment plan is now becoming more and more targeted, and so that people should believe when they have a diagnosis that they can really experience what is now personalized medicine. And so while we may have very thoughtful responses to how we consider CHEK2 mutations, I also want to suggest that there are unique components to every patient that today we cannot necessarily address directly, and that will be best managed by a truly personally designed plan that has a lot to do with not just understanding of the mutation, but the family history that is associated with that mutation as well.
Yes, I'd like to add that a patient who has DCIS or not, and I hope this patient is watching, I'm definitely addressing you as well, whereas I cannot give you medical advice, as Dr. Jeruss said. You really ought to consider being evaluated in a clinic that specializes in understanding the CHEK2 and other breast cancer susceptibility genes that cause a person to be very prone to breast cancer, and CHEK2 is certainly one of them. And you deserve that kind of thorough evaluation where then your cochlear implants or any other metal in your body can be sorted out, but in consultation with a radiologist. And the best enhanced screening that is likely
Yes.
to be recommended can be designed for you.
Yes, exactly.
So rather than us saying here everyone gets an MRI and a mammogram, that would not be good medicine. We need to personalize, as Dr. Jeruss said, your particular case. But if there are other Check2 carriers out there, you all deserve a thorough, long conversation about other screening modalities that you need because you carry this or other genes, because breast is not the only cancer you are at increased risk for. So availing yourself of this consultation in a specialized clinic, such as we have at the Rogel Cancer Center, we're delighted to see anyone who is within reach. Please be sure to contact us. If you're out of state, anywhere in the country, pretty much anywhere in the world, we have listservs where we can provide you with a name and a phone number or some contact in your region. So please call us. We are delighted to assist you.
Thank you both so much for that answer. The next question, can you explain more about genetics and screening and if there's a preferred test?
This is another really exciting time for us to talk about the implications of genetic testing, but also to be, I think, very thoughtful and intentional about the approaches that are taken. And this is why I feel very proud to practice at the University of Michigan, where a specialty clinic exists run by Dr. Merajver to address these exact type of questions, to help design the appropriate panel of testing to be implemented for patients who have a family history or a cancer history that would indicate that genetic screening would be the appropriate component part of their management. And so I think Dr. Merajver, you can address some of these things in a more directed way.
Testing is increasing. Certainly awareness of genetic testing in general is increasing. In 2013, the U.S. Supreme Court decided that certain types of genetic material cannot be patented, and therefore it opened the gates for a lot of different enterprises to undertake genetic testing for cancer-prone genes. Well, this has evolved over time into what we would kindly call a bit of a chaotic situation, but that's what we do in clinic. We put order to the chaos. You can relax. We will talk to you about why we are testing on a single gene or on a panel, and what those genes mean, and what are the likely outcomes of the test. The problem with many people being tested not in a situation where they are properly informed before the test, we call that pre-test counseling, is that they are very shocked when they get the results. And then the practitioner who may have ordered the results is oftentimes equally shocked. And then all of a sudden we get an urgent call, please see this patient, and we are delighted to see the patient. However, I think it's ideal for all of us who seek this information, and this includes me and everyone right here at the table, is to really go from the beginning to a clinic if possible, or to a practitioner who really understands what genetic testing is all about and what will be the implications of you, so you make an informed decision and the whole process is positive, and then you are prepared to make risk management decisions such as increased screening or surgery or taking medicines, and you are completely prepared for that, and going into the test you know that that's an option for the future. So the whole process is beneficial to you, and beneficial, importantly, I'm sure many of you are asking this question because you are worried about yourself, but you are really worried about children or siblings or other family members.
Thank you. Next question we have up, who should get genetic testing?
So in the same spirit, there are a lot of individuals who are now getting genetic testing because it makes a difference in their treatment. And at present, pretty much most patients with ovarian cancer should have genetic testing. Most patients with metastatic breast cancer, I would go as far as to say all patients with metastatic breast cancer. Most patients with metastatic prostate cancer, and that's a lot of men with prostate cancer who previously were not being tested. So these breast cancer genes influence other organs, as I mentioned before, prostate in particular in men, also colorectal cancer and so on. So as time goes on, we find that it is beneficial in many different patient populations to undergo testing. So talk to your doctor if you are a cancer survivor or you are undergoing cancer treatment right now, which makes you a survivor already. Talk to your doctor about whether you need to consult with a high-risk clinic or consult with your own doctor to begin with, whether you should be considering genetic testing. Right now, I can't give you specific guidelines because they occupy about 80 pages, and everyone will really leave us very quickly if I start reciting them. But the important point is, if you are undergoing cancer treatment or you are a cancer survivor, talk to your doctor. And if you have a family history of breast cancer, talk to your doctor.
Thank you. Next question we have up is immunotherapy available for triple negative breast cancer?
Immunotherapy is available for the treatment of triple negative breast cancer. And as we have been saying, I think this is a really exciting time in terms of the translation of care that is existing from recent laboratory research into the clinic. And so if you're a patient that's diagnosed with triple negative breast cancer and you are interested in learning more about impact of trials and your eligibility for trials, coming to a comprehensive cancer center like Michigan would be a place to learn more about how immunotherapy is being brought into the mainstream management for diagnoses such as triple negative breast cancer and HER2 positive breast cancer as well.
Yes.
Thank you. Are treatment options the same for male breast cancer patients?
Well, you know, largely we would still
Largely the
suggest
same.
that surgery would be the mainstay, and then many of the different medical modalities as
Pretty much the
elaborated on
same.
by Dr. Merajver
Yeah.
as well. Yes, and I think that we just want to really say, I think in a broad-reaching base, and it's that these treatments are very tolerable, and we are here to help you and nurture you through the process so that you'll come to the other side. And so again, the mainstay remains surgery, systemic therapies, and radiation therapy, but not all patients need all components of that care. And so this is why coming in as early as possible, being evaluated really is a critical component of coming up with a very appropriate management plan.
Absolutely.
Thank you. The next question we have, how often do women go for preventative bilateral mastectomy?
So this is a very, I think, interesting and somewhat controversial topic. And what we know is that there are many reasons why patients have been more interested in having bilateral mastectomies to date. A lot of this has to do with information that has become more readily available through modalities like the internet. But I think it's important to mention that as we sit here today, we have not been able to demonstrate an endpoint from survivor or from a treatment standpoint for taking away a healthy breast, for removing a healthy breast outside of specific parameters that have directly to do with family history, high-risk family history, and a known mutation that would be identified by Dr. Merajver in the breast care center. And so it's important that we frame and understand why we make the recommendations that we do, and we also recommend, we recognize the limits of what we can do surgically for patients, and this is why each of the decisions to undergo surgery, especially prophylactic surgery, needs to be carefully considered in the context of the patient's known risk from family history, and the risk that Dr. Merajver can help to accomplish very specifically using very specific instruments that assess these factors so that a patient can be given informed consent about the treatment decisions that she may ultimately make.
Yeah, I'd like to go further and say, just add and emphasize, when you have breast cancer, you already heard from Dr. Jeruss and myself that there are many different modalities that can be used to cure you. And if you have metastatic disease, to control your disease for months, years, and hopefully also decades. And this happens all the time. Lots of patients, maybe some of our viewers and listeners, are survivors for 20, 30, or longer years. So in order to get the optimal, the best treatment, you need to have the expertise of all these individuals. If you are going to one practitioner, say a surgeon, and I'm picking a surgeon because the question is about bilateral mastectomies, I would pick a different practitioner if we were about chemotherapy. But say the question about my bilateral mastectomy, that is not a decision a single practitioner should be instructing you to pursue. That is a discussion that needs to take place in a setting that we call a multidisciplinary
Absolutely.
clinic.
Yeah.
That, by the way, we take credit at the University of Michigan for having invented in cancer the multidisciplinary tumor board. And so if you're a newly diagnosed breast patient, please, by all means, go see your local practitioner, whether he or she be the surgeon or your oncologist, but do request information about potentially accessing a multidisciplinary center such as the Rogel Cancer Center, so that you really are aware of all the different repercussions and advantages of each option. So if you choose a bilateral mastectomy, some of you, a very small percentage of you, there will be data that maybe there is a life prolongation by that treatment. The vast majority of you, you are doing it because you don't want a new diagnosis of a new breast cancer that you don't know if you'll ever get. But you don't want the opportunity to have to potentially go through that. Mm-hmm. If you want to eliminate that situation, then the bilateral mastectomy in the hands of a very expert surgeon and reconstruction options are available. So all that you need to explore in the setting of multiple experts serving your case specifically and studying your case. So once that happens, then you'll make the best informed decision for you.
Mm-hmm. Agreed.
Thank you both for that. The next topic we're going to move on to, breast surgery. Do I have a choice between a lumpectomy and a mastectomy?
So I think that that is also a really important question to address, and also can be sometimes a complicated question because many factors go into making the decisions and the recommendations that we will provide once a patient presents to the breast center. I think the most straightforward answer is for a patient who is not known to have a high-risk family history or be a known carrier of a gene that would increase the risk for the development of breast cancer, is a lot of the decisions that we make about the best surgical approach have to do with the distribution of disease in the breast. And we really want to try to offer patients the surgery that will allow them to reach the goals they are seeking to accomplish that have to do both physically and also the psychological well-being in terms of coping and moving forward. But I think the simplest answer is if you're diagnosed early with a small finding that's limited to one quadrant of the breast, you will likely be an excellent candidate for lumpectomy. If you're diagnosed with a finding that spans more than one quadrant of the breast, is thought to be diffuse, or you have multiple findings in the breast, mastectomy is often the best approach to take. But again, is something that we give incredibly thoughtful and careful consideration to before we make any final surgical plan. And if mastectomy is going to be the preferred approach to take, we of course want our patients to also have the opportunity to speak with a reconstructive surgeon about how that component of care will also be able to be seamlessly implemented into the treatment strategy.
Thank you. The next question, what are the different types of reconstruction? What is immediate reconstruction versus delayed reconstruction?
So immediate reconstruction would imply that a surgical oncologist would be teaming up with a plastics reconstructive surgeon so that both teams would be present on the day of the planned mastectomy to to perform the mastectomy, but also immediately implement a component part of reconstruction. And to give, I think, the most straightforward answer possible, an immediate reconstruction can be performed with placement of a tissue expander spacer. It can be performed with the immediate implementation of an implant on certain occasions and for certain body types. Or it can be performed using the patient's own tissues from various different parts of the body to become a new breast form for the patient. And so that would be the immediate reconstruction approach. For patients who will be having delayed reconstruction for various reasons associated likely with additional treatment modalities that will be needed for the patient to successfully undergo management of her breast cancer, that would be when the surgical oncologist would perform the mastectomy alone with the understanding that some point, and hopefully not too far down the line in the patient's care plan, the reconstructive surgeon would be able to come in and make a new breast form for the patient.
Thank you both. The next question up. If I have the BRCA gene, do I need to have a mastectomy?
Well, no. As it's just an extension of what we just discussed. Certainly is the right option for some people. It is often discussed for everyone, but what is right for, again, one individual is not right for another. So we spend a lot of our time with our colleagues and with the patients discussing what's best for the patient, depending on the patient's goals. If you are a young person who wants to have children and breastfeed, obviously you want to keep your breasts, and various other situations. So there is very good enhanced screening. Enhanced screening doesn't prevent breast cancer. It helps prevent a less than favorable outcome because we are diagnosing cancer much earlier. And but this is a discussion in a multidisciplinary setting but you do not need to have the mastectomy in terms of that being your only reasonable option. There are other reasonable options.
Thank you. And, thank you for powering through these questions. They're on such a wide variety of topics, but we want to push on. We have about 13 minutes left. The next question we have, how is metastatic breast cancer treated?
I think we want to start off by saying, and we'll both discuss this, and it's that the expectations for long-term survivorship for patients who have metastatic breast cancer have changed radically in the last 10 to 15 years. And so I want this to be a message of optimism and a message of hope that we are doing more now with targeted therapy, including immunotherapy, as was just brought up in this discussion, to prolong the lives of patients who have metastatic breast cancer. And we have very specific treatment modalities that we will outline for our patients that have a lot to do with their disease subtype, so that individualized treatment plans will be designed for patients that are foundationally based typically on medicines that the patient can take at home, or come to the hospital for short-term infusions for, so that their quality of life with this diagnosis can be very high. And so again, based on disease subtype and very much tailored to the patient's disease distribution, the opportunities for much longer term survival with metastatic breast cancer, I think, is more promising now than it's ever been. Yes. So I don't know if you want to speak more specifically.
Well, I just want to say that, we are at the goal of treatment in metastatic breast cancer is to make the patient feel better, because oftentimes the disease is affecting quality of life. Either there is pain or tiredness. Just having cancer in the body of a particular extent just makes people not have a normal quality of life. So that's the number one goal, is to restore as much as possible the quality of life that you had before your cancer came back, if you were diagnosed at an early stage, as most women are in the United States. So that's the number one goal. It turns out that if that is the goal we keep in mind at all times, not only do we restore quality, but we get longer and longer and longer lifespans as a result, because regardless of how much we actually shrink the tumor, if we shrink it to the point where quality is restored, many of us at any one point in our lives, we can have very good quality living with some cancer in our body. So cancer is not holding us prisoner. We sometimes relinquish our happiness to cancer, but if we can be treated with optimism and hope and try to restore the quality of life of the patient, and that relationship with the treating doctor is very, very important, and the healthcare team and the support at home, then we can achieve months, years, and decades of extremely good quality. So people are reluctant to call things a cure because we don't want to give false expectations, and we always want to be realistic. However, I do believe that we are very close to curing, to calling some people with metastasis cured. I mean, how long is long, right? If somebody lives 20 or 30 years and they achieve close to their normal lifespan, I'm not known in the scientific community for being the most overly optimistic person. I'm very realistic, but I would call that person a cure. And so I would encourage everyone to seek second opinions and to seek clinical trials. We are doing very exciting research, and there are lots of options.
Thank you for that. The next topic that we have is fertility. The first question in that topic: if I have the BRCA mutations but not been diagnosed with breast cancer, should I look at fertility options?
So I think this might be one of the most important things that we talk about together today. And I think that this is really a unique opportunity, again, for us to provide information to our patients who may also be mutation carriers about what's available in 2019 and offer them options for informed consent. And so I want to speak directly to the fact that if you're a young patient with a mutation who's interested in potentially having a child, come to Michigan and be seen by our fertility preservation experts. Our clinic is run specifically by Dr. Molly Moravec here in Michigan. And what she can do is talk about options that exist, specifically through oocyte cryopreservation, using stimulation through standard in vitro fertilization techniques. We can also offer patients embryo cryopreservation with the knowledge now that it's possible for those embryos to then be tested for the presence or absence of the patient's known BRCA mutation, offering the patient the choice to potentially select for embryos that don't have the mutation, so that the experience of being in a family of mutation carriers and carrying that risk of not just breast cancer, but other cancers, as Dr. Merajver has so carefully stated, could come to an end through the generations. And so I just want to state that pre-implantation genetic diagnosis and testing is available now. It's available at Michigan. It's available at centers throughout the United States and the world to offer patients the option to pursue this.
Yes, I have nothing to add. Perfect.
Thank you very much. That is an important topic. The next one we have, and thank you for all these questions that are coming in, on genetics. There isn't a history of breast or ovarian cancer in my family, but some family members have had prostate and colon cancer. Does that mean I am at risk for breast cancer?
You could be. You could be. This is relatively recently, but this is something that in the high-risk clinics, in the genetics clinics, we have known for many years. But recently we have come to understand that depending on the gender distribution, some families have a lot of males, some families have a lot of females and no males. And so what kind of cancers are more prominent in your family is determined by what gender your relatives are. So if all you have is uncles and they all have prostate cancer, you may very well be at increased risk for breast cancer. So family history of cancer is something that is really important to understand. Ask your doctor if you need to be referred to a clinic and a genetic counselor.
I think if you have a concern, we want to see you. We want to help frame your concern and categorize your risk so that you can feel comfortable having the knowledge that your concern matches your risk so that you can act appropriately and responsively to whatever that risk may be.
Thank you. And I think we have time for another question. What kind of clinical trials do you have?
Well, we have
a very large variety.
Yes.
Basically, being a comprehensive cancer center, we have clinical trials ranging from the early detection, imaging studies, prevention studies for people who don't have cancer.
We have an outstanding Center for Radiation Therapy where we're really trying to work as a team, our group that's run by Dr. Jim Heyman in collaboration with other leading experts in radiation therapy, including the incoming president of the American Society of Clinical Oncology, Dr. Lori Pierce, who are really trying to take us into a new way to think about how to manage our patients with the implementation of radiation therapy. And so I want to make mention of that too. It's not just drugs, but also understanding that radiation can be now also potentially more tailored to patients, because that's often a significant concern for our patients when they come in newly diagnosed. And so it's really a dynamic time. And
we will provide, I think, at the end of the webcast, a series of links for people to be able to explore all the clinical trials that we offer. Absolutely. I think that would be very useful.
Again, through prevention and screening and systemic therapy and surgery and reconstruction and radiation, I think patients really need to be advocating for themselves, seeking information, feeling confident of the fact that the information is there, and coming to a place like Michigan where there's a center of excellence and people at the leading edge and all these different fields who want nothing more than to provide care for patients who are in need, for breast cancer and beyond.
Thank you so much. As we wrap up, I always ask, is there anything you feel that we've missed, or do you have any final thoughts?
No, we're here for you. We serve the state of Michigan, tri-state area, pentastate area, anywhere in the world. If you're listening to us, please reach out to us. We're here to help prevent and treat cancer anywhere.
Yeah. Never more than now is this a time of hope and optimism for hopefully identifying long-standing, durable cure for this problem.
Fantastic. Well, thank you both, Dr. Jeruss, Dr. Merajver. Thank you for your time, your expertise. If you tuned in halfway through, this video in its entirety will be on our YouTube, Twitter, Facebook properties. So once again, thank you to our experts and thank you to our audience as well.
Thank you.
Thanks.
For tuning in.
It was great. Thanks.
Thank you.
Yeah, thanks a lot.